asthma, gaining control over asthma is the talk title. These are the objectives that I hope for y'all to accomplish today. How do we evaluate a kid with asthma? Understand the difference between asthma severity versus control, and how we make treatment decisions based on the level of severity or control. And then the end part is going to be discussing the new GINA guidelines, new as in 2019, 2020, regarding rescue therapies. The majority of this talk stems from these two sets of guidelines. On the left, you can see the NHLBI, which produced guidelines quite regularly up until 2012. Those are called the NAEPP guidelines. You might have seen a hard copy of that in our office if you rotate with us. That's where the old stepwise therapy came from that you've probably seen before. Well, they haven't updated it obviously in a long time, but what they've been doing is that group has been collaborating with the WHO and publishing GINA guidelines, and they've been sticking with that quite regularly. And I misspoke there. They specifically say that they are not guidelines anymore, that they are evidence-based strategies to help treat asthma, morbidity, and mortality. And we're going to be talking a lot about the 19 updates at the end of the talk here. Most everything is going to be case-based though, so we're going to try to utilize some real instances of patients to hammer home how we're going to go about the diagnosis and management of asthma. So our first kiddo is an 8-year-old little girl who's got a frequent cough, and her mom is concerned that this may be asthma. This is very basic stuff starting off. So what's your first step in her evaluation? History. Good. Figured y'all get that part. So we want to get a history suggestive of episodic symptoms of airflow obstruction or hyperresponsiveness. So certain things that we would inquire about. What in the world? Somebody mute. So we're going to ask about coughing, wheezing, shortness of breath, and so forth. We want to ask about the pattern of those symptoms and any types of obvious triggers or precipitating factors. So colds, weather changes, certain environmental exposures, cold air, tobacco, and so forth. The big thing to ask about when you encounter these patients: have you been on any treatments before? Has somebody at the ER given them albuterol or steroids? Did it make a difference, or did it really not change things at all? When we're doing our history, not only are we talking about asthma specific things, but you need to ask about other comorbid conditions that we often encounter with our asthmatics, the other atopic things like allergic rhinitis and eczema. Then you also want to ask about reflux, chronic sinus disease, sleep apnea, and so forth. Ask medical history. Were they preemie? Have they had recurrent sinopulmonary infections? If they've been in the hospital, was it bad enough that they had to go to the ICU? Have they ever been tubed before? Family history of atopy is important to inquire about, as is social history. Do they have pets? Do the parents smoke outside? Are they in daycare? All that kind of good stuff. What medicines are they on? And then allergies to both foods and medications. We're of course going to do a full comprehensive exam, but certain things to focus on in regards to the asthmatic would include, why isn't that advancing? There we go. Alert, you can see the kid's allergic shiners there, and these are Morgan-Denny lines that I'm tracing. We can look for an allergic crease. The patient might be doing the old allergic salute in the office as well. Nasal drainage. You can see this really boggy turbinate here on the middle picture. And then don't forget about your differential diagnosis of certain things like CF. And then of course, just bad allergic rhinitis. You might have nasal polyps that you see on the nasal exam as well. chest exam, we're going to be listening to the quality of their breathing. Are they diminished in any way? Do they have wheezes, crackles? Do they have an increased AP diameter? Any kind of chest wall malformations like pectus or scoliosis? And then other things within the other areas of the exam would be, do they have atopic dermatitis? And again, back to our differential, do they have clubbing? You can see that picture there. And remember, not the shape of your nail, it's losing this window here that you can just steer when you have the clubbing. All right, so back to our kiddo. First episode, mom says, occurred at age 3. It's been getting more frequent over the past year. The cough is daily and wakes her up at night, 2 nights per week. Excuse me, the cough occurs once a week, but wakes her up 2 nights per week. Symptoms are worsened by triggers like colds, playing, and weather changes. She's never had any medications directed at possible asthma, no allergies or reflux. Dad's got some asthma and allergies, and the kid's got pretty abnormal breath sounds with end-expiratory wheezing. So we checked that box there. Yeah, that kid's clearly got symptoms of asthma. So you ready to make that diagnosis? Right? What else would you might need to encounter to help firm up that diagnosis in your mind? PFTs, good job. So next step in our evaluation, like you just said, are going to be PFTs. And when we are diagnosing asthma, we got to have the symptoms. You got to have airflow obstruction, which is at least partially reversible when measured by spirometry. That's going to be in our older kids, because remember, it's about 5 or 6 usually before kids can do PFTs reliably. So you don't have to have PFTs, but we'll get to that in a minute. All right, so looking at a PFT, to orient you here, we got the different lung mechanics that we're measuring. We've got 3 main columns: our actual values, our predicted values, and our percent predicted values. We've got a flow volume curve on the lower left and a volume time on the right. So looking at this patient, you can see we got a normal FVC here at 105%. We got a low normal FEV1 of 81. Our ratio is low at 68. And then our 25-75, which is your small airway flow, is also low at 44. How are y'all going to bill for that? What's your interpretation of that spirometry? Good. So obstruction. All right. So let's keep on looking. Now we gave that kid a bronchodilator. So you got new curves here at the bottom, pre and post, and then this is your big bang for your buck, your percent change from pre to post. So this kid's FEV1 went up by 44%. Is that a positive test? Yes. What about a percent change of 5%? Or what's the cutoff? Nope, not quite that high. 12, good. So FEV1 bump up by 12% or more is a positive bronchodilator response. So again, you got some scooping in this curve. You've got a normal shaped curve after albuterol. You've got this 44% improvement in your FEV1. This is clear bronchodilator responsiveness. Everybody understand that before we move on? All right. All right, so we talked about the bronchodilator challenge. Other types of tests that can be done with asthma is plethysmography. Pleth just looks at your lung volumes a little bit more carefully. So you would see residual volume being high in your asthmatics and a high resistance. You can do methylcholine challenges or Colair challenges if needed. That is usually not required though. Exhaled nitric oxide is going to be high in these patients. We really thought that was going to be an awesome test was highly utilized, but it hasn't been so great. There's some limitations in it, I should say. Eosinophils and chest x-ray also are things that might be necessary when you're working up these kids. But your big thing is going to be your pre and post spirometry. So we've checked off our symptoms. We've checked off our PFT findings. Ready to make that diagnosis. Yep. All right. So I agree with you. The only thing you got to remember when we're talking about this is you got to, in your mind at least, be excluding alternative diagnoses. So when we talk about other things in the differential, you can see up here the list is quite long. All that wheezes is not asthma, as you've been told many times, but CF, PCD, immune abnormalities, reflux, structural things like vocal cord dysfunction is a very common masquerader of asthma. Other structural things like tracheomalacia or stenotic airways, heart disease, foreign bodies, BPD, and even infections can all masquerade like asthma. So you're not going to do a workup for all these things. You're not, everybody that comes in for asthma, you're not going to do quantitative immunoglobulin, sweat chloride, everything else. But in your mind, as your history, you're saying, have you been having symptoms of malabsorption? No. CF, much less likely. Newborn screens, normal, much less likely again. So your differential is going to be narrowed considerably just with your history and physical, but you need to keep those in the back of your mind if you encounter a kid that just isn't responding the way you think they should to your treatment strategy, okay? All right, so we got all these things done. Now that we've diagnosed this kid, how are we going to manage her? So now we go to that stepwise therapy that we briefly hit on earlier. And they have these things broken down by age. So you've got less than 6 to 11, and then you've got the adolescents and adults. If you take this chart and it tells you start here if, and there's your symptoms listed out here. So you look at the patient's symptoms, you line it up, you go down to this handy dandy stepwise treatment strategy that tells you exactly what you even start. I mean, they really do a good job with these parameters as helping establish a good foundation for where you actually start therapy and then what you do in long-term management. So if you remember, this kid had symptoms one day a week, but was waking up a couple of nights. So once a week or more at night, that puts us in step 3. Actually, we would even say step 4 because once a week or more. And she had a little bit of low lung function. So we're starting at step 4, medium dose inhaled steroid or LABA. This level of care also you should be referring for specialty evaluation just to make sure they're getting PFTs regularly and being plugged in with somebody that can see them more frequently. You've got other controller options at the bottom. You could do your high dose combo or a lower dose and add on Spiriva or leukotriene receptor antagonist like Singular. So everybody understand how to initiate therapy based on your stepwise treatment? It's honestly pretty easy once you get used to it. All right, once we've made that initial determination, education begins. And that education, a big chunk of it is going to be geared towards your medications. So you got an asthma action plan that's going to tell them exactly what medicines they're supposed to be taking and when they're supposed to do so. You got the green, yellow, and red zones based on their symptoms, and some people use peak flows as well. I'll blow it up here for you so you can see the controller medicines that it tells them again to take every day. But you have your med and your directions for how you actually take it. And then you've got your rescue medications listed down in your yellow and red zone. So in addition to going over the medication asthma plan, you need to make sure that they understand that this is chronic. It's not just when they're having symptoms, which is what a lot of asthmatics think. I don't need my meds unless I'm having problems. How to use their medications, and we'll talk about that a little bit more in just a second. But one of the main things that we encounter for poorly controlled asthmatics is that they don't know how to use their meds correctly. How and when to contact their doctor or ER, and the flu shot is certainly something we encourage our asthmatics to get yearly. Regarding the medications themselves, depending on what you start them on, you're going to be doing device-specific education. So nebulizers, if necessary. Honestly, by the time they come to us, everybody's got a nebulizer, so we don't have to do very much of that. But making sure that they're using it with a mask or a mouthpiece, not doing below the eyes. Take home point for that. The MDI, I meant to grab my inhalers before I came down, but when you push on the metal thing, it's actually shooting out a plume of medicine. So it is driven by an actuator or propellant within that canister. The thing you need to know for that is it does take coordination and timing. If you can't do PFTs well, then you 100% need to have a spacer. In the younger kids, their anatomy is such that they need a spacer until probably around teenager years. Once they're a teenager, or if they're really a good older preteen, spacer and no spacer honestly is equal. But for majority of our patient population, they needed spacers. All right. Holding chambers is something that we use with everybody, like I mentioned. We teach them either with a mask if they're young or with a mouthpiece if they're older. The dry powder inhalers, if they can't do PFTs, they have no business doing a dry powder inhaler. You'll be amazed how many people come in. I'll get them to show me how they do their Advair discus. They hold it like this, push the button. What's happening? All that medicine that they just busted in that blister pack's falling out into the gears. And to prove that to them, the next time you push it, it feels like you've had it out on the beach. You've got all that grit, if you will, in the gears then. Another big mistake is they'll put it up to their mouth and, well, you just pushed all that medicine out, plus you clogged it up with your condensation from your exhale. So it does take a lot of actual, get the device, show them how to appropriately use it, how to load it, how to hold it appropriately, and so forth. And the more of these that come out, the more time it takes, because we have to go through it based on insurance. So the inhaled steroids are kind of our cornerstone therapy. They come in both nebulized, MDI, discus device, and then these twist halers for the asthma necks. The combo therapies are becoming even more, more of them are coming to the market. Now we have the Wixella, the Brio. Used to have just Advair, but now we've got several other products, including Symbicort and Dulera. The big thing to know about these products is what your long-acting beta agonist component is. Advair has salmeterol. These two have formoterol. Don't worry about what I'm about to tell you with these yet. You can do flexible dosing with these because your long-acting, the formoterol, is fast-acting enough that you get that rapid onset of action. You get the quick relief necessary from the albuterol component. The salmeterol has a much longer time to peak onset, so you don't get that immediate relief that you need when you're having bronchoconstriction. And you'll understand what I mean when we talk about the GINA guidelines a little bit more about rescue therapy. Spiriva is relatively new. If y'all haven't seen that used yet, that is one you 100% need to spend time with your patients. It comes in two different parts. They have to be shown how to put it together, how to use it. It is completely different than any of the other inhalers. One thing for y'all to know is it can be used with the spacer in the younger kids. You just put it in the back of the spacer tube, and when you actuate it, it's almost like a little mini nebulizer. It shoots out the mist for about 10 seconds or so. Well, you just get them to actuate it in the spacer first, then the kid puts their face up and inhales. So you can use the Spiriva and the little ones as well. Leukotriene modifier, Singulair, is an extremely common drug. If y'all don't know already, Singulair can cause kids to be the devil spawn, and I'm not exaggerating. I mean, it can really rock a parent's world if they don't know that it's a possibility. The way when I tell people that, I say, look, this can cause some crazy behavior stuff. It's not going to be subtle. You're going to be saying, oh, this is what he was talking about. And if you experience it, stop it. It's not going to get better until you stop it. But once you do stop it, it's very short-lived side effects, but it's impressive when you see it. The albuterol, everybody knows the different trade names of the various albuterols. I did want to point out that there is a DPI now. So if you write ProAir and the patients call you up late at night and say, hey, this doesn't look anything like you showed me, they have a dry powder one called a Respiclick. So they might have been given that by the pharmacy instead of the MDI. And just know again that that is a breath actuated inhaler. So it's not appropriate for the little kids. All right, long time since we visited our case, but let's go back to it. We started her on Advair 45/21, which is a low dose combo therapy, and then as needed albuterol. 2 months later, she comes in to see us, and how are we going to assess her therapy? Well, again, based on symptoms and PFTs, instead of looking for our initial therapy, where are we starting this kid? We're saying, are they well controlled, not well controlled, or very poorly controlled? And we're basing that categorization on those symptoms and PFTs that we visited on our initial assessment. But our goals are to reduce impairment and reduce risk. So we want to minimize symptoms, normalize lung function, and reduce the chance for severe exacerbations or lung function loss. There's lots of other things written on here, but those are the main, that's the gist of it. We're reducing impairment and reducing risk. We're determining our level of control again by our history. And then they also have some questionnaires, and I bring this up for y'all that might be going into primary or just general peds. This asthma control test is something that you can easily administer or have your office staff administer and have it ready for you when you walk in the door. So this is a questionnaire. If you're 12 or older, this is the form you would get, and you answer these questions, you tally up the score. If you're 19 or over, you're well controlled. If you're not, if you're less than that, then you're suboptimal control. And the little kids, they give a two-part thing. One, the kids are answering the questions with these little pictures, and then you've got 3 questions for the adults to answer, and still tallying it up and scoring it the same way that I mentioned earlier, with 19 kind of being the cutoff. All right, so our kid says, totally feels great, rarely having any symptoms, no exercise limitations, no nighttime symptoms, and she's only used albuterol once. We got a completely normal asthma control test and normal exam. Now look at our PFTs. We got a normal FVC, normal FEV1, a normal ratio. We have no bronchodilator responsiveness and a totally normal curve. So this kid's got normal PFTs now, no symptoms, rare albuterol requirement. How are y'all going to classify her control? Well controlled. That one's pretty obvious, right? All right, so again, back to our GINA guidelines. They've got it a little plugged in to where you can just go by your symptoms and PFTs and answer these questions, and that helps you to label them accordingly. Once we do that, we're going back to our stepwise therapy. So for that example, I chose step 3 as our starting point. After we've had a few months of control, we're going to assess whether or not they've been doing well enough to drop down, and we would take a step down to the low dose inhaled steroid. If the reverse was true, if they're not doing well, their PFTs are abnormal, you're going to do the opposite. You're going to be stepping up therapy. And this is a dynamic thing. I mean, it can vary based on the time of year. If they've had a cold, if the mom started brought home a new dog or started dating somebody that smokes, whatever. So it can change considerably in a very fast amount of time. But if you're well controlled, step down. If you're poorly controlled or not well controlled, you're going to step up. Going back to severity for a second, you remember the mild, intermittent, mild, moderate, and severe persistent categories. Used to be those last set of guidelines, that was the first step. And then from then on, you're assessing control. Now what they're saying is you actually ought to be waiting to classify that severity until you see what is required to control them. So you can see down at the bottom here, you would say they're mild if they're well controlled with just step 1 or 2. The moderate kids need step 3, and severe needs step 4 or 5, or even still is uncontrolled at max therapy. Like I mentioned, it's very fluid. So you might say one day they're severe persistent, and in the winter you see, or summertime you see them and they act more like a mild intermittent kid. It's not something that you got to go changing on your EMR every time, but just know it can change with time and age. All right, so let's do another case real quick. We got a 13-year-old guy with asthma, appropriately diagnosed. He's needing albuterol multiple times a day. He's got a nighttime cough and exercise limitations despite being on high dose combo and Singulair. He's had 4 rounds of steroids. He's got an asthma control test of 10, which if you remember, 19 is the cutoff for being controlled versus not controlled. And we got a lot of wheezing and prolonged expiratory phase. So kind of going back through what we talked about before, how's this kid's level of control? Very poorly controlled. Go back to our little stepwise therapy. You're going to say, let's go up, right? Well, we're at max. So what are we doing now with this kid? That should be done for sure. Good. Get them, show me your medicines, call pharmacy, go through the device education again. Make sure mom didn't throw the spacer away or the dog ate it. Make sure that they know how to do, that they are not doing their albuterol twice a day instead of their Dulera. All those kind of things. What else? Okay. Exactly. So that's something that's always in the back of your mind. Am I even treating the right thing? What about you're treating the right thing, but your control is just problematic because of other things? Okay. Yep. Environmental exposures. Good. What else? What other comorbid conditions impact our level of asthma control? Allergies. Good. What else? Obesity, definitely. And along those same lines, OSA can as well. What's another big one? People that are obese and have OSA oftentimes have this as well. Reflux. So they get reflux. So those are your comorbid conditions that you got to assess. So we're checking their medicines. Are you doing it right? Are you getting refills? All that kind of stuff. Looking into comorbid conditions and environmental factors. We talked about those already. And the big one in the middle that I forgot to mention that needs to be in the back of your mind is going to be ABPA. The asthmatics and CF kids are the ones that we'll see ABPA in, and they get better with the steroids, but it's like they have to have them constantly. Don't forget about ABPA. How do you diagnose ABPA? What's the main lab abnormality they're going to show you on a test? Huh? Eosinophils? Good. That's not my answer. So it's a real high IgE. So you got a high IgE, you got specific IgE or IgG to Aspergillus fumigatus, you've got eosinophilia. okay, and a positive skin test for aspergillus. All right, so back to our case, negative reflux and OSA, got a lot of allergy symptoms. Total IgE is only mildly elevated, which doesn't go along with ABPA. ABPA levels are through the roof. And then he's got numerous allergens by immunocap testing. So what are we going to do with this kid? Well, we got all the different medications that y'all are used to seeing with the antihistamines and nasal steroids. Amaryl or those guys might say, hey, this kid would benefit from immunotherapy and get them on that. But the other big thing is here at the bottom, and you're going to see more and more of the biologics as time goes on. We've got 3 now that are approved for kids, and those are the first 3 that you can see highlighted in yellow. The oldest one is Xolair, which is your anti-IgE. The 2 newer ones are Fasenra and Nucala, which are both IL-5 products. They're stopping the inflammatory process through blockade. They work differently in that cascade, but they're both IL-5 products. And then there's another new one that's not yet approved for kids, that's an IL-4 receptor antagonist. So if you've got a kid that's requiring real aggressive therapy, is atopic, has a lot of eosinophilia, has allergic, other atopic features, that's something that you need to at least consider. And I promise you, we have seen a marked reduction in their other maintenance therapies in the patients that have been put on this. So it's a pain. You got it. They're mostly sub-Q or IV, IM, excuse me, but IM, IV, or sub-Q. But they do tend to work quite impressively. All right, I mentioned a couple of times about the GINA guidelines, and there was a humongous change in 2019 regarding their reliever treatment options. So you can see at the bottom the crux of it, and that's that GINA no longer recommends treating adults or adolescents with short-acting bronchodilators alone, but they should receive symptom-driven or daily corticosteroid-containing inhalers. Let's look at that a little bit more. The reason behind this is the following. These huge percent of patients with acute asthma, near fatal asthma, or those that died were fairly asymptomatic over the 3 weeks or so prior to those events, and were more categorized as mild. And remember, we talked about how fluid that categorization can be, and this kind of highlights that. Exacerbation triggers are highly variable, so is adherence. And then we know that albuterol, people start to kind of rely on that. They think of it, that makes me feel better. That's what I need to treat my asthma. So what's the problem with the albuterol? Well, number one, they begin to use that instead of their maintenance. Number 2 is they use it regularly. You get beta receptor downregulation. So I become immune to it, you're becoming immune to it. You're losing receptors over time, and you get decreased bronchoprotection and more of a rebound phenomenon. We also see an increased allergic response and increased eosinophilic inflammation with regular albuterol use. The outcomes associated with regular albuterol, if you dispense more than 3 canisters a year, you get higher risk of emergency department, and more than 12 per year associated with a higher risk of death. So because of all that, they started doing several studies looking at, is albuterol as a PRN drug the best treatment, or do we need to be doing other things? And what they found was that the other things were much more successful in all those endpoints. So decreased ER visits, decreased exacerbations, decreased total inhaled steroid dose use. And what they recommended is that you either take an inhaled steroid along with your SABA, so you're short acting. So if you've got a ProAir, you also get a Flovent. Anytime you need to use your ProAir, you're using your Flovent along with it. So 2 puffs of each. The other alternative goes back to what I mentioned to y'all about the combo therapies and which ones have the faster acting LABA. So the ones that have formoterol, you can give them the inhaled steroid formoterol combination and say, use this when you're having problems. So you're accomplishing their goals of SABA plus inhaled steroid at the same time. And they talked about why they do it as population level risk reduction strategy. Yeah, whatever. It works. All right, so how do we know it works? Well, there's several studies, this START study and practical study. Look at those endpoints there. Reduction in severe exacerbations with small or no difference in symptom control and a lower average inhaled steroid dose. So what are parents always concerned about with inhaled steroids? Growth and being heavy, that kind of stuff. So you can utilize this information to show them that they can actually get away with a lower overall inhaled steroid dose doing it. Furthermore, the inflammatory markers were significantly reduced in that strategy that we just discussed. All right, so now what do we do with this piece of information? All right, going back to what we talked about originally. Remember, we got the less than 6 group, we've got the 6 to 11 group, and then we've got the adolescents and adults. So this is just for the adolescents and adults. What they recommend, if you're having infrequent asthma symptoms up here at the top, you can either do as needed combo inhaled steroid with formoterol. So that's your Symbicort and your Duleras. Or you can do that dynamic dosing is what they call it. That's when you put inhaled steroid with your short-acting beta agonist. All right. If you have more than twice a month, that's when they say you ought to be on an inhaled steroid with an as-needed SABA. Or again, you can just stick with that combo therapy using it only as needed. So their thoughts are if you're needing it twice a week anyway, at least this way you're getting the inhaled steroid with it and your endpoints are better than doing the short acting alone. If you have symptoms most days or waking once a week or more, that's when they're going to say to use the low dose inhaled steroid LABA combination as a maintenance and reliever. Or you can do a medium dose product with as needed albuterol. So let's take that bottom possibility off the list. That top one is what we call adjustable maintenance dosing. So the way I would say this to my patients is I'd say, okay, every single day I want you taking your Dulera 2 puffs twice a day. If you have problems, you take another 2 puffs every 4 hours as needed. So it's the same thing you would do with the short-acting beta by the PRN part of it, but they're getting the inhaled steroid every time they need the short-acting reliever. Okay? What's the problem you're going to encounter with this strategy, either one of these? Not with us or our families. Who's going to be the problem? Insurance and the pharmacy. So you gotta, it unfortunately sometimes takes a little bit more legwork on your end to explain to them why they need 2 canisters of their Dulera, because they're going to get 2 twice a day and as needed, they're going to burn through more than 1 canister in a month, right? So people are getting the message from this. We've been yelling at pharmacies and insurance long enough that y'all probably won't have to do it quite as much, but just know that that is going to be something that you have to discuss with them. The other thing is these as needed, the asthma action plans that we've got, they're not really set up to give you that kind of strategy. There are a couple of newer asthma plans that we're looking at that to maybe employ some of these strategies with. But just so you know, those are 2 options out there, either the dynamic dosing, saying take your Flovent and your albuterol anytime you're symptomatic, or the adjustable maintenance dosing, using your combo therapy as a maintenance and PRN. All right. Anybody got questions about that? Right. Adults and adolescents only. That's right. That's correct. Yeah. By the guidelines. All right. So the initial therapy for the adults and adolescents, we're not going to go through this whole slide, but look here at the bottom, preferred reliever, as needed, low dose inhaled steroid plus formoterol. Not even talking about your short acting as your preferred. It gives you that option, but the preferred is going to be the combo therapies now. And then when we're assessing control in those adults and adolescents, again, our preferred relievers are the combo therapies. When you're assessing control, this is where it gets a little sticky. So you're getting more inhaled steroid than what you would normally when you're having an exacerbation, right? Instead of getting 2 puffs twice a day, you might be getting 2 puffs 6 times a day during a flare-up. That, they say that that should not factor in to determining your overall level of control. I'm not sure that that's the most appropriate stance for this. I think if you're requiring something that much, you probably better be thinking about stepping up or adding an add-on therapy like the Spiriva or the Singulair, but just know that they say otherwise. They say that that shouldn't actually factor into your level of control. Okay. All right, so take home points here. All right. So our diagnosis of asthma requires 3 things: the symptoms, the PFT findings, and then the alternative diagnoses being excluded. Remember, in the younger kids, we're not going to have the luxury of PFTs. So you got symptoms, you try the therapy. If they're getting better, or they have other atopic features, have family history, they've got asthma. You don't have to call them reactive airway disease. Asthma certainly can present earlier than we can get PFTs on them. And then make sure you're excluding other diagnoses in your differential. Control is the big key, regardless of the severity. The severity can fluctuate. Your control is the big thing we're focusing on, regardless of that level of severity. And we're utilizing our history, our questionnaires that we talked about with the asthma control test and spirometry to figure that out. Make sure you're reassessing and re-educating every time you see these kids. Are you doing your medicines correctly? Let me see you do your pump. Any changes in the household, anybody smoking, all those kind of things. That it happens all the time. And if you're not asking, then you're going to be beating your head against the wall trying to figure out why that kid's requiring so many steroids. Control your comorbid conditions. So likewise, if your allergies or reflux is out of control, you're going to have an enormously difficult time controlling that kid's asthma. And then the big take-home message, in my opinion, is that bottom bullet, and that's the use of the combo products for both rescue and maintenance in your adults and adolescents. I know that's kind of a big shift from prior guidelines, so that's why I wanted to emphasize that and hammer it home. But that's what you're going to be seeing a lot of. I think we talked about the younger kids. I think it's going to trickle down as we get some more trials that are ongoing right now. I would not be shocked at all for that to be the recommendation for the 6 to 11-year-old next year, as early as next year. The younger kids, it'll probably take a little bit longer before they're willing to go that route. Okay. Anybody got any questions? Everybody knows how to do asthma now.
What different helps those differentiate?
So what I think of as reactive airway disease might not be what you say. I call it viral induced wheezing, and that's just kids that the only time they ever wheeze is when they get a cold. So they got snotty nose, coughing, wheezing, short of breath, need albuterol, have to get steroids, that kind of thing. Outside of colds, no symptoms whatsoever, no other triggers like play, nighttime, weather changes, exposures, any of that stuff. So I think those kids, the viral induced wheezers, the evidence-based medicine is totally 100% different than your asthmatic. There's no good data to support maintenance medications in those kids, and it's just albuterol as needed with steroids if they have a bad enough flare up. There's a few small studies that say that that is the one place where Singulair might be beneficial over other products, but there are just as many that say bull crap. That's not the case. The asthmatics, if they wheeze outside of colds, I push them right into the asthma category. And you're not hurting anything by labeling them that. So if they're just with colds, I say this is a viral induced wheezer. If it's anything else, then it's more of an asthmatic.
Dr. Brown, is that
Hey,
is that similar?
absolutely.
Is that similar then for the adolescent and adult? Like if they only wheeze when they get sick, but otherwise they're fine, or they only have a cough with exercise, but then they're fine, do you still do the inhaled steroid?
You talking about the dynamic dosing and the maintenance dosing thing that we just discussed?
Yes.
That's a great question. They didn't break those out specifically. I will tell you that people that have exercise-induced only symptoms, a lot of times if they are not just controlled with prior to exercise symptoms and they're still having some, prior to exercise albuterol, and they're having some breakthrough stuff, then I put those patients on controllers anyway. So doing this for them is certainly reasonable. They're getting the benefit of the long-acting beta with that kick of the short-acting or the fast-acting component of the formoterol, and then you're also protecting them with the steroid. I don't encounter very many older kids and adults, well, no adults, but older kids that just have problems with a cold. If I did, I probably still would say just PRN, inhaled steroid formoterol, based on this data. Did that answer you? Take that as a yes. Anything else, y'all?
Yes, thank you.
Okay. Got anything on y'all's end about that? Anybody doing it? Sure, where else? No. It's a big fundamental shift. So it's going to take some time for it to be the norm now. All right. Y'all have a great day.